Hello everyone, hope you all are doing very well. Today we are going to discuss procedural mishappenings in a dental clinic during endodontic treatment. This is one of the very important topic from the board exams point of view. You're definitely going to see quite a few questions from here. So let's dig right in. Procedural accidents, they can be of different types, such that accidents during cleaning and shaping of root canal system, inadequate canal preparation, or they can be obturation related. Then there could be instrument aspiration or extrusion of irrigant. Now we're going to discuss these one by one. So with every accident, mishappening or error, there are going to be three kinds of questions. One could be from the basics. Second could be from prevention. So, how to prevent it or how to avoid it. Accident has not yet happened. And then third are going to be the treatments. So, once the accident has been done, error has been committed, now how we are going to treat it. Let's start from the loss of working length. One of the very common error we note it on a radiograph that is taken with master cone or master apical file. It would appear short of the established working length. How do we prevent it? We should use sound reproducible reference points. With curved canals, we should always pre-curve all instruments that we are going to use. Always use sequential files. For example, start with 10, 15, 20, 25. So always use them one by one. Do not jump from 10 to 25 straight. When verifying the instrument position radiographically, use consistent radiographic angles. Always maintain the original preoperative shape of the canal. Copious irrigation and recapitulation throughout cleaning and shaping of the procedure. Proper irrigation methods. So there is no treatment of loss of working length. Once it's done, it's not possible to undo it. So we should take proper prevention methods to prevent it at all cost, because there is no way we can undo the loss of working length. Next comes the ledge formation. Ledge is an artificially created deviation of the root canal wall which prevents endodontic instrument to establish working length. Let's have a look at the ledge, how it looks. So this is how a ledge looks. Formation of ledge by use of stiff instrument. So a straight instrument has created a ledge here in a curved canal. How does it happen? By forcing straight instrument short of working length in a curved canal. Rotating the file at working length causes deviation from the natural canal pathway, straightening the canal, and creation of ledge in dentinal wall. Rapid advancement in file sizes or skipping the file sizes. How we can prevent a ledge? We should always use flexible niti files or stainless steel patency files that are specially made for this to determine canal curvature. Accurate evaluation of radiograph and tooth anatomy, pre-curving the instruments for curved canal, use of safe-ended instruments with non-cutting tips, use of sequential filing, avoid skipping instrument sizes, frequent irrigation and recapitulation. So now we have created a ledge. How we are going to treat it? We have to bypass it, choose a smaller number file, usually 10, 15. Give a small bend at the tip of the instrument and penetrate the file carefully into the canal. Once the tip is apical to the ledge, it is moved in and out of the canal utilizing ultra short push and pull movements. with emphasis on staying apical to the defect. When file moves freely, it may be turned clockwise upon withdrawal to rasp, reduce, smooth, and eliminate the ledge. When ledge is bypassed, then efforts are directed toward establishing the apical patency with the number 10 file. Let's look at this. Correction of ledge. Ledge is bypassed by making a small bend at tip of instrument. Bend instrument is passed along canal wall to locate original canal. Next comes the instrument separation, one of the very common, very important, frustrating problem in endodontic treatments, which occurs due to improper use or overuse of instruments while working in curved, narrow, tortuous canal. Why does this happen? Sometimes there is variation from the normal root canal anatomy or overuse of damaged instruments or dull instruments. No proper irrigation methods or excessive pressure while inserting in canal, improper excess cavity preparation. So how do we manage it? Treatment. When an instrument fracture occurs, first of all, take a radiograph to evaluate curvature and length of canal, accessibility of instrument, location of separated instrument, and amount of dentine present around the instrument. One of the technique to manage this condition is file bypass technique. Very important. A small sharp bend should be given at the end of the instrument to bypass the broken instrument fragment. We insert the file slowly and carefully into the canal. When negotiation occurs past the fragment, one will find a catch. Do not remove file at this point. Use small in and out movements along with copious irrigation of canal. Once the patency with the number 15 instrument is achieved, shift to K-reamer. Use pull, rotate, and withdrawal method movement rather than filing motion. Every time reamer rotates, there will be clicking sound as the flutes brushed out against the file fragment. One must avoid placing an instrument directly on top of broken file. This can push it deeper, resulting in loss of patency. If the file is visible at this point, it is possible to use a small tipped ultrasonic instrument or 1/4 turn withdrawal type of handpiece to dislodge and remove it. So, instrument retrieval. To remove separated file, we first expose it with the help of modified Gates Glidden drill. We can remove it. It is modified by removing its bottom half and thus creating a flat surface and performing crown down technique. Then use this modified GG grill to enlarge the canal to a point where instrument is located. This way a platform is created which enables to visualize the broken fragment. Thereafter, a small tipped ultrasonic instrument is used to flush the file out. Then, if instrument retrieval becomes impossible, sometimes we have to go to surgical management. It is indicated when broken file is behind the curve or file fragment is not visible because of the curved root. Let's have a look at it. So this is how a separated instrument looks like on a radiograph. So this is before the obturation and this is after the obturation. In this case, it might have been impossible to retrieve it. So they have bypassed it and filled the canal. Here, see, surgical instrument, it was bypassed and then final obturation has been done along with it. If it's not causing any harm, we can leave it there. But if it goes beyond the apical canal, then we cannot leave it here. We have to surgically remove the canal. In this case, the whole tooth has been removed. Prognosis of instrument separation. Prognosis depends upon timing of separation, status of pulp tissue, position of separated instrument, ability to retrieve or bypass the instrument. So, separated at later stages of instrumentation, when almost the canal is completely clean and close to the apex, have better prognosis than if it separates in undebrided, short of apex, or beyond apical foramen. So, in the apical third and completely clean canal, instrument separation has best prognosis. Now comes the prevention of instrument separation. General methods: discard instrument when there is bending, corrosion, or dulling, unwinding of fluids, excessive heating of instrument. Instrument separation in endodontic occurs mainly as a result of metal fatigue, cyclic and torsional fatigue. This is the main reason for instrument separation. Instead of using carbon steel, use stainless steel. Use smaller size instruments only once, and always use instrument in sequential order. Never force instrument. Canal should be clean, irrigated properly. Never use instruments in dry canal. Always clean the instrument before placing it into the canal. Debris collected between the flutes retard the cutting efficiency and increase the frictional torque between the instrument and canal wall. Do not give excessive rotation to instrument while working with it. So now that we have talked a little bit about cyclic and torsional fatigue here because it's the main reason, let's talk a little in detail about them. Cyclic and torsional fatigue, very important topics. Cyclic fatigue of the files. If a file is placed in curved canal, so cyclic in curved canal, the outer surface will be in tension and inner surface will be in compression. If the file is rotating in curved canal, the file will be subjected to repeated tension and compression, causing separation of the instrument even if it was not deformed, and results when strain develops in a metal. So this is what happens. For example, if we have tooth with a curved canal, and there is forceful or repeated push and pull movements of a file. So this is what will happen. There will be tension on this side and compression on this side of file. The repeated tension and compression, what it's going to lead to, there will be small fractures in the file which will lead to the proper fracture of this file. Then comes the torsional fatigue. Why does this happen? Due to the friction resistance. This is not in curved canal, it could be in straight canal. Locking the flutes of a file in canal wall while continuing to rotate the coronal portion of the instrument is an example of torsional fatigue. File fracture occurs more frequently with rotaries, but may also involve hand instruments such as K type and H files. This can be reduced by limiting file contact using crown down technique, by verifying a glide path to working length, and with the presence of irrigants. So this is what happens. For example, imagine this is a file going inside the canal of a tooth. That's a really bad drawing, sorry. So this is a file, and let's see here. It's rotating this way. Imagine it gets stuck here. It gets stuck inside the tooth here, and from the top keeps on getting rotated. So what happens is there will be fatigueness here and the file will break. That's about cyclic and torsional fatigue. Now let's talk about zipping. It's defined as transposition of the apical portion of canal due to improper shaping technique. Terms given to describe this shape: hourglass shape, foraminal rip, teardrop shape. It happens due to failure to pre-curve and forcing the instrument. So when a file is rotated in a curved canal, a biomechanical depth, an elbow is created. Remember, always elbow is created in zipping. Is formed coronal to the elliptical shaped apical seat. This is the narrowest portion of canal. In many cases, obturating material terminates at the elbow, leaving an unfilled zipped canal apical to elbow. So this is how zipping looks. This instrument, it was not properly curved. So what happened is it increased the apical foramen size. Basically, there is transposition of apical portion of canal. This area is still thin, but this has been increased. This is also called zipping. So this, as we can see here, this is the elbow, this portion, narrow portion, and then from here it's wider. Another example of zipping. So how we can prevent zipping? Again, recurve the files, use flexible files, incremental filing technique, remove flutes of file at certain area. For example, file portion which makes contact with outer dentinal wall at the apex portion, which makes contact with inner dentinal wall, especially in the midroot area, by overcurving in apical part of file, especially when working for severely curved canals. Next comes the canal transportation. Apical canal transportation is moving the position of canal's normal anatomical foramen to a new location on external root surface. It's pretty much similar to zipping. Now, see here. Type 1, 2, 3 canal transportation. There is minor movement of apical foramen, then a little more, and then there is severe movement of the apical foramen. Next comes the root canal perforation. Again, very important. Can occur at three levels: cervical canal perforation, mid root perforation, and then apical root perforation. Cervical canal commonly occurs when locating canal orifice, flaring of the coronal third of the root canal. There will be sudden appearance of blood from canal is the first sign of perforation. Then there's mid root perforation, commonly occurs due to over instrumentation and over preparation of thin wall of root or on concave side of the curved canals. Sudden appearance of bleeding is pathognomic feature. Then comes the apical root perforation. It occurs when instrument goes beyond the confines of root canal and by overuse of chelating agents along with straight and stiffer large sized instrument to negotiate ledge, canal blockage or zipping. So root canal perforation is on the outer side of root, this side. When there is perforation on this side here, it's called furcation perforation. We'll talk about it later. Now we are only talking about root canal perforation here. So how do we manage it? So treatment goal is to position the defect above crestal bone. Orthodontic root extrusion is generally the procedure of choice. Best management for teeth in an aesthetic zone. Surgical crown lengthening may be considered when the aesthetic will not be compromised or when adjacent teeth require surgical periodontal therapy. Internal repair of these perforation by MTA has been shown to provide an adequate seal compared with other material. Ideally, repair of these perforations should be done as soon as it happens to prevent the damage to the periodontium. Access to the mid-root perforation is most often difficult and repair is not predictable. Very important. Mid-root perforation is the worst and repair is not predictable in mid-root perforation case. So why it's important to position the defect above the crestal bone? Let's talk a bit about it. So let's assume okay, that's a bad diagram again, but let's assume this to be the coronal third. So you know somewhere here there is crestal bone, right? And this is the coronal third portion. This is the mid of it. So if there will be perforation somewhere here, for example, it's coming from this side and there is perforation here above the crestal bone, we can easily repair it from outside, from inside, right? If it is right at crestal bone or a little below it here, what will happen? This bone, it will identify this perforation and start adjusting according to it, right? So what will happen? There will be pocket formation. So if it is close to the height of crestal bone, what we do is we try to adjust the crestal bone so this perforation is exposed and we can repair it from outside and inside properly. So there is no pocket formation to avoid the pocket formation. But if it is below crestal bone and we can only repair it from inside, there is no access from outside, we do not know how we have repaired it. It's possible that bone again it identifies the external material or defect itself, any external body, and it starts creating a pocket here, which is a very bad prognosis from periodontal point of view. That's the reason we need to keep it above crestal bone. Next comes its prevention. Again, pre-curved files should be used. Modified files, file can be modified by removing flutes of the file at certain areas. For example, file portion which makes contact with outer dentinal wall at the apex, portion which makes contact with inner dentinal wall, especially in the mid-root area. Using anti-curvature filing, that is, more filing pressure is placed on tooth structure away from the direction of root curvature and away from the invagination, thereby preventing root thinning and perforation of the root structure. Look at this here, perforation caused by use of stiff instrument. Now, very important, prognosis of root canal perforation. So, one of the very important factor for the prognosis of perforation repair is its location. If the defect is located above the height of crestal bone, it's the almost the best prognosis, favorable prognosis. Teeth with perforation at or below the crestal bone in the coronal third of root have the poorest prognosis. So even if the mid-root portion has a bad prognosis, the perforation at or below crestal bone is the worst. Okay. Then size, small perforation has better prognosis, visibility and accessibility. If it's visible and accessible, it has good prognosis. Time, again, important factor. Perforation should be appeared ASAP to discourage further loss of attachment and prevent sulcular breakdown, as we talked about the periodontal complications. So, associated periodontal condition, if attachment apparatus is intact without pocket formation, non-surgical repair is recommended, whereas in the case of loss of attachment, surgical treatment should be planned. Aesthetics influence the perforation repair and material to be used for repair of the perforation. Next comes furcation perforation. It's generally of two types: direct stripping. Direct perforation usually occurs during a search for a canal orifice. It is more of a punched out defect into the furcation with a bar and is usually accessible, may be small, and may have walls. This type of perforation should be immediately repaired with MTA. If proper condition exists, for example, dryness, glass ionomer or composite can be used to seal the defect. Prognosis is usually good if the defect is sealed immediately. Then comes strip perforation. Let's have a look at it and then we'll talk about it. So, direct perforation in this area, this area, this area. This is called furcation perforation. And this that you can see here in this green circle, this is strip perforation. This is a danger zone for a tooth. It curves in such a way that it's always possible to cause strip perforation in this area. The focal region of molars at the level of curvature, danger zone, is a common site of perforation. Note down the concavity in the furcation area of this mandibular molar. Strip perforation occurs more commonly on inner side of the curve. So, strip perforation involves furcation side of the coronal root surface and results from excessive layering with files or drills caused by over-instrumentation through a thin wall in root, most likely happen on the inside or concave wall of curved canal, such as distal wall of mesial roots of mandibular first molars. Very important, please note this down. Whereas direct perforation are usually accessible and therefore can be repaired non-surgically, stripping perforation are generally inaccessible, requiring more elaborate approaches. The usual consequences of untreated stripping perforation are inflammation followed by development of periodontal pocket. Long-term failure results from leakage of the repair material, which produces periodontal breakdown with attachment loss. Skillful use of MTA has significantly improved the prognosis of non-surgical repair of stripping perforation compared with other repair material. Next comes the post-space perforation. Iatrogenic perforation during post-space preparation are usually caused by poor clinical judgment and improper orientation of the post-preparation drills. Can be recognized by sudden appearance of blood in the canal or radiographically. Treatment of post-space perforation involves the same principle as for repair of other perforations. Dental amalgam, calcium hydroxide, GI, composite resins, freeze-dried bones, calcium phosphate can be used to repair this. How we can prevent it, evaluate proper anatomy, and avoid excessive use of GG drill or piezo reamers to cut the dentine. Let's have a look. This, as you can see here, post space perforation. Now we are moving to complications due to inadequate canal preparation. These can be over instrumentation, over preparation, and under preparation. So, over instrumentation is excessive instrumentation beyond the apical constriction, violates the periodontal ligament and alveolar bone, leads to increased risk of overfilling, lack of adequate apical seal, pain, and discomfort. It is recognized when hemorrhage is evident in the apical portion of canal with or without patient discomfort. So, over instrumentation is usually in the vertical direction. Apical constriction has been lost. There are chances of overfilling and over preparation, excessive removal of tooth structure in mesiodistal and buccolingual direction. So, for example, this has been widened mesiodistally, buccolingual direction. When the canal is widened in these directions, it's called over preparation. In this case, there are increased chances of stripping and perforations. And then there is under preparation, which is failure to remove pulp tissue, dentinal debris, and microorganism from root canal. It can be in any direction. Under preparation could be vertically, horizontally, in any direction. Here it is. Inadequately shaped canal prevent three-dimensional obturation of root canals. This is under preparation, and due to the under preparation there is also underfilling. Here there is overfilling of canal. This, see how wide it is. Overfilling of the canal causing irritation to periapical area here. There has been a radiolucency created all over. Next comes obturation related mishappenings, which can be underfilling or incompletely filled root canal. So if it's underprepared, it will also be underfilled, or it can be underfilled or on its own. Underfilling is obturation of root canal greater than 2 mm short of the radiographic apex. So you have only filled until here, and this has been left greater than 2 mm short. So if it is 2 mm short, it is still acceptable. Until 2 mm, it's acceptable. Greater than 2 mm short is not acceptable. It is called underfilled. Can happen due to inaccurate working length determination, inadequate irrigation, or due to presence of a ledge. Inadequate removal of infected necrotic tissue in apical portion of root canal results in persistent bacterial infection. Thus, initiation or perpetuation of existing periapical pathosis. Next comes the overfilling greater than 2 mm beyond radiographic apex. Remember again, 2 mm is acceptable, greater than 2 mm is not acceptable. Poses risk of forcing infected root canal content into the periradicular tissue, thereby impairing the healing process. May cause foreign giant cell reaction and may act as a foreign body which may support the formation of biofilms. Next comes instrument aspiration. Aspiration or ingestion of instrument is a serious event but easily avoided with proper precautions. How we can do it? Use of rubber dam. First of all, the standard care to prevent such ingestion or aspiration. Disappearance of an instrument that has slipped from dentist fingers, followed by violent coughing, gagging by patient, and radiographic confirmation of the file in the alimentary tract or airway are the chief signs of instrument aspiration. These patients require immediate referral for medical service. Surgical removal is required for some swallowed and nearly all aspirated instruments. So we always need medical referral, medical attention for instrument aspiration. Once it is confirmed that instrument has been aspirated, there is no way we can treat it in a dental clinic. Next comes the extrusion of irrigant. Again, an important one. Wedging of a needle in a canal or particularly out of the perforation with forceful expression of irrigant, usually sodium hypochlorite, causes penetration of irrigant into the periradicular tissue and inflammation and discomfort for patient. It can cause life-threatening emergency, usually called sodium hypochlorite accident. It happens most commonly in maxillary posterior area diagnosed with pulp necrosis and periapical lesion, but it can be avoided by loose placement of irrigation needles, careful irrigation with light pressure, and use of side perforated needle. In addition, it is recommended to place a rubber stop on the irrigation needle shorter than working length to stay away from apical ferment during irrigation. Up-down movement of needle during irrigation also helps to prevent locking needle inside the canal. Sudden, prolonged and sharp pain during irrigation followed by rapid diffuse swelling usually indicates penetration of solution into the periradicular tissues. Acute episode will subside spontaneously with time. In teeth with open apices, use of less concentrated irrigant or saline will prevent the possibility of irrigation accidents. Initially, there is no reason to prescribe antibiotics. If there is a visible swelling, an incision and drainage is recommended to reduce pressure. Treatment is palliative, analgesics and steroids are prescribed, and patient is reassured because the outcome is so dramatic. Evaluation is performed frequently to follow progress. So this is how scary it can look. So this is sodium hypochlorite accident. It was inadvertently expressed through an apical perforation in maxillary cuspid during irrigation. Hemorrhagic reaction was rapid and diffuse. No treatment was necessary. The swelling and hematoma disappeared within few weeks. So we just have to assure the patient that it will go away, it will be fine. It's possible that patient starts panicking, but this does not need a treatment. It could be painful, might need analgesics. So this is the end of our topic today. Thank you so much for watching.